All right. Good afternoon, everyone. My name is Imano Mukambo. I'm the head of the capacity building of head of capacity building unit of the Cortex Club, and I welcome you all to today's presentation. So today's presentation is a continuation of the Neuroanatomy Series, and today's presentation will be delivered by Mwitupa Makashinyi, fourth-year medical student at the Copperbelt University, pursuing a bachelor's degree in medicine and surgery. So Mwitupa, kindly share your screen and get started with the presentation.
Right, thank you, Mano, for the introduction, and thank you everyone for joining us. As was already mentioned, my name is Mwitupa Makashinyi. I will not reintroduce myself, so let's get right into it. Now, I won't be able to see if you send any messages here in the chat box. So if you have a question for me, if you have anything to say while I'm speaking, just unmute and interrupt me. You're very much allowed. All right. So, as already mentioned, this is the Neuroanatomy Series for 2022, and my topic is the White Tracts. So, previously, you have already gone through the nervous system. Emmanuel led you through an overview of what the nervous system is, the central nervous system, the peripheral, and then you went on to talk about the structure of the brain and its parts, and partly the spinal cord as well. And then you had a presentation from Rudo on the blood supply to the brain, and the last presentation before mine was on the basal ganglia. So just a brief recap of where we are in the series. For this afternoon, what I would want us to go through is what a tract is, and then we'll discuss the ascending and descending tracts, and we'll talk about lower and upper motor neurons, and then I'll just mention and define the motor and somatosensory cortices, and then we'll go through some clinical correlates as well. All right, so what are the tracts? Tracts are basically neural pathways made up of nerves that are with the same origin, the same course, and the same termination. So basically, nerve fibers that are doing the same job, when they're bunched up together, it's called a tract. So the white tracts are a special type of tract, which are made up of just the axons of the neurons. So there's gray matter, which is made up of the cell bodies, but then white matter is made up of the axons. So that those myelinated sheath-like, structures have a white appearance, which is why they're called the white tracts. Now, white tracts are divided into the ascending and the descending tracts, and then the descending tracts are also further subdivided into the pyramidal and extrapyramidal tracts. So I've put a note at the bottom that says, don't confuse the white tracts with the white matter tracts. So something that, maybe some of you are not like me, but for me, when I see things which are similar, I tend to think, oh, it's the same thing. It's not. White matter tracts are made up of commissure fibers, association fibers, and projection fibers. So that's just purely within the brain. Whereas the white tracts are within the brain, the spinal cord, and they extend up until even your limbs. So I hope that distinction is clear. So white matter tracts are just for the brain, and then white tracts are the brain, the spinal cord, and even your limbs. Okay. All right, so something that we had, as I'm teaching this, I'm bearing in mind that most of you are SOM students. And so what was important in third year for me last year would possibly be important for you to know, I think, and I hope. So something that we were asked in our sessional was about we were told to draw and label a cross-section of the spinal cord at the thoracic level. Yes, some of us might even be scarred from that question, but yes. So basically, I thought it would be important to tell you about the different cross sections. I've moved to the next slide because this one I think was a bit more simplified. So this one took at least about 7 or 8 cross sections, whereas this one just has the 4 main ones. So it's important to note that there's, like I said, there's the gray matter. I hope that you can all see my pointer. Could somebody just confirm?
Yes, we can see it.
Yeah.
Great, thank you. So this is the depiction of the gray matter, and then this is the white matter on the outsides, right? So gray matter, and you've got the dorsal horn, and then you've got the ventral horn. So in my research, I stand to be corrected, but most textbooks and most literature say that there's a dorsal horn and a ventral horn in each cross section, but then in the thoracic section specifically, there's also a lateral horn. So I'll zoom in there a little bit. Sorry. Yes, here. You can see there's quite a distinction, whereas here it's mostly rounded. All right, so next slide. What do you need to know about the White Tracts? So firstly, you need to know the location on the spinal cord. Where is the tract located? And then you need to know which sensation is carried by that tract. And then there's this funny word called decussation. So a decussation is basically a crossing over. So you'll need to know at what level, because most of these tracts cross over to the opposite side. So you'll need to know at what level they do that. Right. And then something else I thought it would be important to define is a column or a funiculi. Basically, same thing. A funiculi is Latin for a cord. So columns or funiculi are cords that transmit the tracts. And why is that important for us to know? So if you saw this diagram, I put it earlier, but it's reappeared because of this a funiculi. So on the peripheries, remember we talked about white matter and we talked about gray matter. So gray matter, I've already told you, there's the dorsal horn, lateral horn, ventral horn. And then for the gray matter, there's the columns. So gray matter has horns, white matter has columns. So there's the white dorsal columns here, that's this entire area. And there's the lateral columns, and then there's the ventral columns right here. All right, so if we're clear, I can move and we can start talking about the tracts. Just anyone to confirm that up until here, no questions. Great, thank you. So here we've got 2 diagrams. Sorry. Let me move that here and that there. All right, there we go. So we've got 2 diagrams. And I think one thing that I've noticed about neuroanatomy is it's very important to look at lots of different diagrams, because if you just see this, you think, oh my word, no, there's no way I'm going to get all this in my head. But you see something like this, and it's a bit more, colorful and more demarcated, and you think, okay, so it's not so bad. But just don't get confused and think that some things are only on one side of the spinal cord. So this is a very simplified diagram. This is more realistic, but this one's easier to understand. So like I said earlier, we've got the ascending and the descending tracts. So on this side, these are the ascending tracts, and then here these are the descending tracts. And it's one of the ways that it's easy to tell which one's descending and which one's ascending is from the names. So if you hear spinocerebellar, it means it's coming from the spine and it's going towards the cerebellum. Spinothalamic, coming from the spine, going to the thalamus, and so on and so forth. And then on the descending, you've got corticospinal, you've got reticulospinal, so it's coming from the brain going to the spinal cord. Right. So the ascending tracts, there's basically 5 of them. So the first 2 are the lateral and the anterior spinothalamic. Now, as I said earlier, you can tell starts with spine, goes to the thalamus. So the point where the origin is for the spinothalamic is there are certain pressure sensors all over your body. Because this is just an overview lesson and not a very detailed dive into the White Tracts, I didn't think it was necessary to mention, oh, this is the the Pacinian corpuscles are the ones which you detect crude touch or fine touch or anything like that. I didn't want to go in too deeply to the point where we end up getting confused. So just as an overview, take it that what's transmitted is from sensors over the body. So for the lateral and the anterior spinothalamic, the lateral spinothalamic tract, as mentioned here, transmits temperature and pain. So remember I said there's three things that you need to know about each tract. So one, the sensation that is transmitting. So for the lateral, we said temperature and pain. For the anterior, crude touch and pressure. Then we also said the position on the spinal cord. So as you can see, lateral spinothalamic is from the lateral column. And then the anterior spinothalamic is from the anterior. So the third thing that we said you need to know about each tract was the level of the decussation. So here, they decussate in the substantia gelatinosa. Yes. So in the top right corner, you can see that it says first order, second order, and third order neurons. So this is basically just after each synapse, you change the order. So the first order was here from the receptors on the body up until the spinal cord. That's the first order. Then from here up until the termination point in the thalamus, not termination point, the synapse in the thalamus, that's the second order. And then from the thalamus up until the cortex, that's the third order. So that's it for the lateral and anterior spinothalamic. Then we get to the dorsal column. So the dorsal column is made up of two. I'll go back to this diagram so that you can see what it looks like in the spinal cord. So there's the fasciculus gracilis and the fasciculus cuneatus. Now there's two ways that I like to go about remembering this. One way is that when you do lower limb, you'll remember that in the lower limb, there's a muscle called the gracilis muscle. So the way I used to remember that the gracilis was for the lower limbs is that, there's a gracilis muscle, so fasciculus gracilis for the lower limb. But another way that you can remember is the fact that the fasciculus gracilis is more medial than the fasciculus cuneatus. So fasciculus gracilis being more medial, one of my friends likes to remember that, your legs are medial to your arms. Your arms are more outward. They're more lateral on your body. So the fasciculus cuneatus, which is more lateral, deals with the arms. The fasciculus gracilis, which is more medial, deals with the legs. So whichever way you find it easier to remember, that's what you can use. So that's it. And you can see on this diagram, it says from the nucleus, which is nucleus just being a bundle of neurons. So the nucleus gracilis coming down up until the lower limb, and then the nucleus cuneatus, upper limb. I'm not sure why they put the lower limb higher than the upper limb, but like I said, whichever way you find it easier to remember. And then, what did we say the third thing? So we've talked about what we didn't mention what sensations are carried. Sorry about that. The sensations which are carried by the dorsal column tracts is fine touch. So for the previous ones, the spinothalamic, that's crude touch and then pressure, temperature, and pain. But for these, the dorsal column, it's fine touch. And I think for me, I found it easier to remember that because I would say to myself, well, our hands and our legs are involved with, we touch objects, we walk, there's a lot more, what would I say? There's a lot more fine movements associated with our limbs than would be needed to sense pressure or sense, other things. So that's the way that I found that easier to remember. Okay, and then the position on the spinal cord, as was already seen, it's in the dorsal column, hence the name. All right, and then the last types of ascending tracts are the anterior and posterior spinocerebellar tracts. All right, yeah. So the anterior and posterior spinocerebellar tracts, location in the dorsal column and also in the anterior column. And then what sensations do they transmit? The spinocerebellar tracts are involved with gross movements and with unconscious proprioception. So a little bit about unconscious proprioception. There's conscious proprioception, which is where, and the dorsal column tracts are involved with that, which is where you are aware of the items, you basically are aware of your surroundings, right? So that's what proprioception is. Unconscious proprioception is the proprioception that you don't really have to think about. So we all have things that are, I think an example of this would be the clothes that we wear, right? So up until when you first put on, say, your shoes, right? You can feel that you've put on your shoes, but after a certain point of time, you don't think about it. You don't actively think, oh, I've got shoes on my feet every few seconds. It just becomes, a part of what's on your body. And then when you take them off at the end of the day, you don't feel like something is missing constantly because your body has adjusted. So that's a little bit about proprioception. It's just the awareness that your body has of your surroundings. So that's what the unconscious bit of it, the conscious bit of it is done by the dorsal column tracts, but then the unconscious part of it is done by these, the anterior and posterior spinocerebellar tracts. And then the funny thing about these two is that the posterior spinocerebellar tract or the dorsal spinocerebellar tract does not decussate. So if you can look at this diagram here. Yes. Oh, there we go. If you look at this diagram here, you can see that this tract is just going straight up. It's not crossing over onto the other side. Whereas for the anterior one, it crosses over in the pons. Right. Okay. Now the clinical correlates. Oh. Sorry, I typed in two. Well, I think it didn't save them. But the two clinical correlates that I wanted to bring to your attention were one called tabes dorsalis. Let me just type that now. Yes. So tabes dorsalis is basically a complication that comes after a person has syphilis, and either it's untreated or it progresses and possibly becomes neurosyphilis and then starts to affect their nerve fibers, etc. So basically what happens is the person is now no longer able to feel some types of sensation for particular types of stimuli, and then for others they're hypersensitive. So backtracking a little bit, the white tracts are responsible for, like we said, there's the ascending tracts and the descending tracts. So the ascending tracts are sensory, the descending tracts are motor. So when you lose sort of the control that you have over sensation, it means that there are certain stimuli which, we've just spoken about proprioception, right? There are certain stimuli which you don't need to be sensitive to. And then there are other stimuli which it's dangerous not to be sensitive to. So tabes dorsalis basically means that there's destruction of the nerve fibers to the point where some stimuli which you aren't supposed to be feeling, you are, and vice versa. The stimuli which you are supposed to be feeling, you are not. And then the second one that I wanted to bring to your attention was, I'm sorry, I typed these out, but then Google Drive sort of lost them. Okay. So this was the second one. So no specific name, and causes are, well, causes can be anything really, any damage that a person sustains to their spinal cord. It can be in a car accident, it can be just trauma, it can be a fall, anything that would potentially damage your spinal cord at any given level can either result in contralateral or ipsilateral loss of sensation. So remember how we've been speaking about the decussations, right? I'll give this one, I'm looking for a clearer one. There we go. As an example. So let's say before the substantia gelatinosa, somebody gets an injury to their spinal cord, right? So there, something happens. If you get injured before the decussation, so that's here, then the loss of sensation will be ipsilateral. But if you get injured after the decussation, which would be here, then the loss of sensation would be contralateral. So an example that was given was imagine you've got a patient that is suffering from they can't feel crude touch on one side of their body, and so things like we once had a class on how to test the cranial nerves, and so things like a cotton swab, and you rub it over your patient's skin, and they're able to feel it. That's an example of where a patient wouldn't be able to discriminate crude touch. Or you put something hot near your patient's skin and they can't feel it. So then it just becomes a question of, okay, at which level of the spinal cord is this injury? Where is the lesion, basically? All right. So those are the two clinical correlates I had for you, just under the ascending tracts. Are there any questions so far?
Hello, can you get me?
Okay, I can't hear anything.
Dorsal column decussates.
May you repeat that?
There's a question in the chat box asking the location of decussation of the dorsal column.
Oh, okay.
Oh, yeah. Sorry, I was having challenges with
Let me go.
So I think someone has already mentioned something concerning the question on the dorsal columns. So I don't know if you tackle the questions now, or you'd rather tackle them at the end of the presentation.
Okay, if it's something like a something like the question which has just been asked, at least I can go back to the diagram before we move on.
Yes, the question was where do the dorsal columns decussate again?
Okay, hold on, let me get the diagram. Here. Yes. So unless somebody has a more detailed whoa. Sorry about that. Power had gone here, so it's just come back. Yes, unless somebody has a more detailed answer, all I found was in the spinal cord. So it said something about how in the medulla here, but this diagram probably isn't the best one because here in the medulla it's already decussated. But it said something about how in the medulla that's where the decussation is. So I don't know if the response to the question in the chat box is similar.
I think it is.
Okay. Yeah. All right. So let me go to that. If there are no other questions, which I can answer immediately, I can go to the descending tracts. Yes. All right. So descending tracts. Like we said, they can be divided into pyramidal and extrapyramidal. So when we say pyramidal, we mean inside the pyramids of the medulla. So let me go to the diagram. So here are the pyramids of the medulla. There's just these raised structures, and they've got very internally. The shape is actually I don't know if you can see this. So internally, the shape extends just beyond even this. what we can see here. So it's very, what's the word? You need to imagine it. It's very difficult to imagine this just as you can see it here in 2 dimensions. You need to think very 3-dimensionally, which is something that we're learning to do as we go on in the Neuroanatomy series. And then also another feature of the pyramids is the fact that you can see the decussation on the pyramids. So there were more lifelike diagrams, but I felt that this one was at least simplified to the point where you can see it in relation to other structures as well. So don't get confused. It's not these types of pyramids. Right. So pyramidal tracts versus extrapyramidal. So there's the main ones. There are also, in fact, I forgot to mention this as I was concluding the ascending tracts. If you noticed, there were some that I didn't mention because, like I said, not to dig too deep. This is just an overview. There are other tracts which exist, but those were the main ones. So the same with the descending tracts. I will not tackle each and every single one of them, but the main ones are there. So there's the descending tracts. We already know that they are responsible for motor. They're responsible for movement, and so they take instructions. They take information from your brain to the rest of your body. So all the way down through your spinal cord at different levels. So the corticospinal and corticobulbar tracts are what are some of the main descending tracts. They're usually used interchangeably, except corticobulbar deals with your head and neck, and then corticospinal deals with the rest of your body. So they have the same pathway, like the exact same pathway, like through the brain, etc. And then they'll just branch off as they reach lower in your spinal cord. So they're not usually differentiated on diagrams. If you check corticospinal versus corticobulbar, you'll get the same diagram. So there's 2 types. There's the anterior corticospinal and the lateral corticospinal. And remember we said you have to know where it is on the spinal cord. So that's here, lateral corticospinal in the lateral column, and then anterior corticospinal in the anterior column. So here and there. And then the type of they terminate in the cortex. So it goes they originate in the cortex, and then they go all the way up until your motor neurons in your body. The decussation is at the pyramids, as already stated. So that's one of the tracts that decussates there is the anterior corticospinal and the lateral corticospinal. Then we have the rubrospinal. So the rubrospinal tract goes from the red nucleus. Again, we're not going to go too deeply. From the red nucleus, and you can see it here, up until your motor neurons. So the decussation is at some point in the midbrain. So before the pons, it's already decussated. And then here's for the extrapyramidal tracts. The 2 main types are the reticulospinal and the tectospinal. So I don't have a diagram of the tectospinal, unfortunately, but here we have the rubrospinal and the reticulospinal. And then back to the diagram of the spinal cord so that we can see where they're placed, which columns they're in exactly. So on this side, and you can see the other types of descending tracts as well, the ones I haven't mentioned. There's vestibulospinal here. Reticulospinal is in 2 types. There's the medullary and the pontine, and then there's the tectospinal as well. So like I said, all of these are concerned with motor innervation. So they all hit the motor neurons, and they deal with motor activity. Now, for the clinical correlates, so it's not labeled clinical correlate, but that's what it is. So descending tracts are continuous with upper and lower motor neurons. Now, what are those? Upper motor neurons and lower motor neurons are basically the neurons which are involved with, motor activity. We've already said that. But upper motor neurons are within the brain up until the spinal cord, and then lower motor neurons are the ones which start in the spinal cord and then go to the rest of the body. Now they have different functions in the sense that upper motor neurons often deal with reducing, basically controlling movements, and lower motor neurons deal with regulating movements. Now I realize that doesn't sound very different, but the difference will show as we get to what happens when each of them gets damaged. Like I said, we had this question in our physiology sessional, if I remember correctly, and it was worth 10 marks. So here's a table, two tables of some of the differences that can be highlighted when we are asked what the difference is between a lesion on an upper motor neuron and a lesion on a lower motor neuron. So upper motor neurons, when they're affected, can cause spasticity and rigidity in the muscles, whereas for the lower motor neurons, it'll cause hypotonia. So I think the next table explains this better, in the sense that it mentions that with lower motor neuron lesions, you have reduced effectiveness of the muscle, whereas with upper motor neuron lesions, what you'll have is more frequent the muscle will sort of be acting up, in the sense that there's frequent movements and uncontrolled, yes, that's the word I was looking for, uncontrolled movements. So the person is no longer in control of their limb, for example, or their leg. Their foot will just have these spastic movements and clonic movements that they can't necessarily control. Then we'll have the types of muscle weakness which will be present in either the upper motor neuron lesions or the lower motor neuron lesions. I won't go into detail explaining each and every one of these, but just to give you a brief overview of what the difference is between the two. And I think the best resource, one of the more detailed resources, which I'll give in my references, was Magdi, because it's more on the physiology, so it was very, very detailed in how it described each of the different types of lesions. So in the upper motor neuron lesions as well, you can expect to see increased deep tendon reflexes, because remember I said that upper motor neurons are more concerned with controlling the movements, and then lower motor neuron lesions were more concerned with. I think I should have said upper motor neurons are more concerned with regulating, and then lower motor neurons are more concerned with controlling. Yes. So you can see here, most of these are due to a lack of being able to regulate. So the movements will be more outside the patient's control. They will not be able to determine how weak or how strong or how powerful they want the movements to be. So in that sense, they're no longer really in control of what they can do with that muscle group. Yes. So then things like fasciculations and then twitches and muscle wasting, etc. So something that I found interesting was the fact that for the upper motor neuron lesions, muscle wasting would only be caused by the fact that the patient would no longer want to use their muscle, because now they're no longer in control of it. So any movement that they do would be exaggerated, or it would just be, it wouldn't be what they would want to do. So muscle wasting occurs, but it occurs much, much later on, because it's just that person now deciding. It's not that the muscle has wasted in and of itself. it's because the patient does not want to use that part of their body anymore, and so then the wasting will be eventual. Other tables, like I think this one didn't mention muscle wasting because it's not one of the prime, it's not one of the early signs of an upper motor neuron lesion. The lower motor neuron lesions, wasting is usually present because that person is it atrophies, the muscle atrophies because they cannot use that muscle anymore, or that muscle group. All right. So that's it on the descending tracts, unless there's any question.
Okay,
not even in the chat. Okay, no. Not even in the chat. All right. So we're going to now talk about the primary motor and primary somatosensory cortices. So the primary motor cortex is sort of where the origin for most of the nerves. Let me zoom in a little bit. Yes, the origin for most of the nerves which carry motor information originate from. So the organization is like this. Remember I said that in this neuroanatomy series, we've had to learn to think three-dimensionally. Wow, tongue twister. We've had to learn to think three-dimensionally. So here, this is the lateral view of the brain. We can see they've sort of split it open so that you can see both hemispheres. And right here is the primary motor cortex. So most literature defines it as being after the central sulcus, and then that's when you have the motor cortex. You also hear it defined as Brodmann's area 4. That's why there's like that tiny 4 under there. And then this is the organization. If you view the brain, if you're viewing a transverse section, not sagittal, not transverse, that section. You can see medially here and laterally there. The way it's organized is your lower limbs are more medial, like the control is more medial, and then as you go laterally, you've got the hands, upper limb control, and then the face, lips, tongue, jaw, and so on and so forth as you go laterally. So like I said, it's just an introduction. That's pretty much all you need to know about the motor cortex. And then there's the somatosensory cortex. It doesn't have its own diagram, but it's here. But it's not given any color. It's just this one, which says 312. So it's right next to the motor cortex. And the somatosensory cortex is really where the sensations reach. This is where those nerve fibers which transmit sensation terminate. Yes. Very, very brief. And then I was told to give more resources that people can check out if they want to read more about this or when the topic comes up academically. So KenHub videos I found were very, very helpful. Ninja Nerd videos and also the Indian textbook Magdi were very helpful. And that's the end of my presentation.
Well, thank you very much for the presentation, Mwitupa. Was very concise and so much detailed, I'd say, and highly elucidated and all. I don't think there are any questions in the chat box. Oh, there's a question from Ebenisha. He was saying he has a question on the previous slide. I think the slide before the sensory cortices.
This one. This one.
So the slide before that. Yes. Benish, is that this slide?
This one?
Yes.
This one?
Benish, you can go ahead with your question.
Yes, everyone. Thank you so much. Yes, everyone. Thank you so much. Yeah, my question is on... sorry. The next slide, slide 20.
Okay, that's okay. That's okay.
Okay, thank you. Yeah, my question is on deep tendon reflexes and about neuron lesions. Yeah, where it said increased, but in brackets there was something like, but superficial reflexes such as abdominal reflexes are usually absent. So I wanted to know why that is the case.
I see. Well, I don't have. I didn't go. I didn't go into further detail as to why that would be.
I would have to get back to you on that one.
I would have to get back to you on that one.
I think I
remember in physiology classes, there was something that was given to us about how the Babinski reflex, because that's one of the reflexes which is present under plantar response and one of the ones which becomes exaggerated is the Babinski reflex. But how that related to the abdominal reflexes being absent, I'm not sure.
All right, thank you so much.
All right, thank you so much.
Okay, all right, thank you. I think this is maybe we can just like take it down and maybe try to research a bit more on it, and then we can continue giving our answers in the WhatsApp group as more material is going to be shared on the same topic. I think this is very much helpful to lay a basis for building knowledge, because we can't exactly get everything at once. But I think the more we're exposed to the information that is being presented in this series, we'll be able to easily grasp the information once we are exposed to the information more and more. And yes, so just to contribute to what has already been mentioned, I think this is a very important topic, which covers a lot of information that we would actually encounter in clinical scenarios. So, for example, if we talk about things such as incomplete transection, spinal cord injuries such as the Brown-Séquard syndrome, where you have an incomplete injury of the spinal cord, and then you have loss of motor function on one side of the body, and loss of sensation to pain and temperature on one side of the body. That's having a proper understanding of how the tracts run and those such things, as well as having an understanding of some of the components that we already discussed in these other segments or sections of the Neuroanatomy series would actually give you an upper hand, as well as a good basis for making your clinical decisions or clinical judgment. So I think these are some of the most important reasons we should have at the back of our minds as we're attending these Neuroanatomy series. Then we are still continuing with the Neuroanatomy series. I think we have like 2 more presentations left in the series, after which we'll be able to tackle other things other than neuroanatomy. But I'd like to believe these are things that we're all still going to find helpful, and I hope everyone will be available. I've noticed a couple of individuals who are joining us for the very first time. I hope this will not be the last, and we'll still be coming through. And another thing is that we have the vice president in our midst, Champion. So Champion, kindly unmute yourself and give any remarks that you may have for the presentation and anything else concerning the club, especially the Brain Awareness Week and other activities coming up.
Thank you very much, Mwitupa. That was an excellent presentation. Though it brought some horrifying memories from last year's session, but it was really brilliant. I learned a lot. Yeah, so it's actually a very nice way of revision. So if this could be made available, like all other videos on YouTube, it can help out with revisions, especially towards the term 3, for those who are going to be doing CNS anatomy. Yeah, so thank you very much for the presentation. And with regards to the Brain Awareness Week, I think we'll give announcements in the group if anything comes up. So thank you very much also, Emmanuel, for organizing this series. They are very informative.
Thank you. So yes, once again to the presenter, this was a very brilliant presentation you just gave, and we've benefited a lot, and I'd like to believe there are some aspects and concepts that you've contributed to what we already know. I think this marks the end of our presentation. If there are no questions, we'll be closing the meeting. So I'll just give maybe 5 seconds to anyone who may have questions to indicate so.
Maybe or maybe just the question to Mukambo. Is there any way where the last question that wasn't really cleared can be made available? Of course, it's our homework as the Codex Club, but how can we make it available in case we come across the answer?
I think it can be communicated via the WhatsApp group. So if there are any individuals that are not in the group and would like to be, I think you can get in touch with any of the executive members. And if you are interested to find out what the findings for that question would be, I think you can you'll most likely get the feedback from the group. So if you're not in the group, you can get in touch with any executive members, and then we can add you to the group, and then we can do the needful.
Thank you.
Sure. You're most welcome.
Thank you.
So like I said, this marks the end of our presentation. Have a pleasant day.